and so we are going to go ahead and get started. Hopefully I've set up this panel well for our discussion. This panel is entitled ACOs, PCMHs, VBP, Integrating Equity into the New ABCs of Healthcare Reform and Payment Reform. We're joined today by Tom Lee. Tom is Chief Executive Officer, Partners Community Healthcare, Inc., and Network President for Partners Healthcare, Inc. I will say that we're not going to spend time reading bios. They're all in your packages, so the detailed bios are there. Tom, thanks so much for joining us. We're also joined by Brian Smedley, Vice President and Director of the Health Policy Institute at the Joint Center for Political and Economic Studies. Brian will also be wearing a different hat at lunchtime today in his role as the lead author and study coordinator for unequal treatment. So Brian, thank you for coming up. And let's jump right in. This is a group of people, I think, who's interested, obviously, in the issues of equity. And what we wanted to do with this session was really kick people off and give them the basics of both what's happening in the area of payment reform as well as healthcare reform. Both of you are expert in these areas, spent a lot of time living it and studying it. So, Tom, I want to begin with you. In basic terms, orient us to some of the key issues of payment reform as you see them and things that would be important for this audience.
Well, and so you want me to start by taking like,
yep.
you know, like 10 minutes and say a few things
yep.
without slides. And, and I'm happy to do it. And welcome to Boston. And I think it's wonderful you took time to step back to think about how do we advance this agenda with the special pressures and special opportunities of our time. This is a moment of discontinuity. This is a moment where our idealistic aspirations and pragmatic imperatives just might be converging. And you know, to use language that's maybe a slightly cruder than I usually use, but to convince you that the people who are running delivery systems really understand that things have to change. I can tell you, I'm on the board of Geisinger Health System, and last week we were in a meeting, and you know, the CEO, who's like a former surgeon, is very direct and blunt. He said, if we don't figure out how to make managed Medicaid work, we're screwed. You know, because you know, payments,
scientific term.
Yes,
right?
yeah, and you all know what it means.
Yeah.
And so the imperative for people who are, you know, managing organizations to think about how do they redesign care so they're doing business other than being paid for office visits, paid for x-rays and so on. It's an imperative. You can either be an iceberg that's melting slowly or quickly, or you can try to reinvent yourself. And that's what all of these letters are about. In Massachusetts, we're a little bit ahead of the rest of the country. I think that 2014, you know, the changes in the rest of the country will, I hope, start to accelerate. June 28th, when the Supreme Court upheld the Affordable Care Act, was like one of the great, most important days for all of us. Now, I would suggest that, you know, think of healthcare reform in 3 levels. There's insurance reform, there's payment reform, and there's delivery system reform. And what happens when legislators pass laws like the Affordable Care Act and Massachusetts healthcare reform is really the top level. It's insurance reform, you know, commitment to covering, you know, nearly everybody or a good chunk or more than we've currently been covering. You know, some decisions about where the money is going to come from and how much money there's going to be. That work is very important, but it's only the beginning. Payment reform are then taking the money that's available and paying people in different ways. You know, like giving people choice of fee-for-service with, you know, progressively diminishing payments or frozen payments that aren't going to increase over time, or offer them the opportunities to get paid differently if they will get organized and try to perform as a group to take responsibility for an organization, to be an accountable care organization, to do value-based purchasing where you get, you might make, you know, make more money or get hurt less if you're able to deliver various types of performance. But changing the payment model from CPT level fee for service, CPT level meaning like an office visit based, you know, that's CPT things are all about what I do as a doctor, how long I spend with a patient. These other payment models are about what actually happens to people. delivery system reform, which is frankly what I consider the good stuff, which is like how do providers actually work together to take care of people. That's what most of my day job is like, and looking around the room and seeing some familiar faces, from many of you as well. So think about those 3 levels, and they are different, and we shouldn't just blur healthcare reform together. Now, I think that I believe what we're seeing in Massachusetts is a logical and I think irresistible process for change for the better. Change for the better being very, very painful, miserable, in fact, because no one, change is miserable, but it is change for the better. And I think the sequence is you commit to covering everybody, or nearly everybody, and that creates the context where the costs of care become extremely political. And that leads politicians and regulators who are trying to show their leadership and fulfill their other duties to threaten to do things which would have lots of unanticipated consequences. And that leads people like my colleagues and me who have talked an idealistic game all of our lives to suddenly go, wait, don't do that. That will be really miserable. Let us try to get organized and take capitation, take responsibility for something other than doing visits, and for the first time, actually get challenged to live up to what we say, what we say in academic talks and the articles we write, which is meet the needs of population. So I think that if we don't if we don't commit to covering everyone, that sequence doesn't happen. It's always easier to deal with financial issues by uninsuring people and underinsuring people. So for improvement in general, covering everyone, it is, the #1 issue. It is the core of everything, and so we have to start that. We can't waver from that nationally. But starting that in process, that sequence in process where provider organizations actually have to figure out how to meet the needs of a population so we can cover everyone. The last 3 points I want to make is the first thing is organizations have to have a discussion and decide what it is they're actually trying to do. They're not just trying to generate visits and make money to pursue lofty, fluffy missions, which are good. I don't mean fluffy in a pejorative way, but they actually have to step back and say, what we're trying to do is, in our organization, what we say is improve value. I actually don't use the words quality or equity very often. Quality is a word that means so many things to different people. It's kind of lost its meaning. I don't use the word equity because, I'm trying to, I think that sounds like an advocacy group as opposed to some, the phrase improvement of value, that's something that speaks to all the stakeholders. No one is against that. Everyone is for being better. Everyone is for improving the outcomes of all patients and doing it reliably, regardless of their ethnic background or socioeconomic status or their medical issues, and also doing that as efficiently as possible. So improvement of value is what we talk about as, and changing what we measure to drive that. I mean, the meeting I just came from 7 to 8, was about creating a center that's like creating the marketplace for value, for our system and hopefully beyond. The second thing I'd say is that a lot of you know Steve Shortell's comment about, organizations don't change until they get to like 30% of their business being paid for in a different way. I think it's completely right. Now, I've met Steve Shortell over the years, and I can tell you that 30% is based on no data. He made it up. And he was asked in a meeting, like, when will people change? And he said, oh, when about 30%? And then it got quoted. But he was trying to say, you need a lot of the business, but not most of it. And I think that that's true. So I think that driving organizations into pioneer ACOs and commercial capitated contracts to get them, as we have in the last year, partners up to 40% of their business in capitated contracts, that changes the idea of what performance actually means. And I hope it means it's becoming improvement of value over time. And then the third thing I would say is that a very specific agenda that I think will resonate with many of the people who I know here is building social capital. Like, that's a phrase I didn't even know of a couple years ago. But increasingly, it's clear that organizations need financial capital to get things done. They need to be disciplined about accumulating and managing their financial capital. They need to be every bit as focused on accumulating and growing social capital, the way that clinicians work with each other, the way that patients work with the system. Organizations that have trust and that have clarity about how people are going to interact and so on, these organizations are more efficient and more effective than organizations where everything is being discovered for the first time and negotiated for the first time. So as some of you who I know where some of you work, and you go back to your job, begin thinking, it's building trust, building social capital. It's not a nice to have. This is like an imperative for the environment that we're going into. So with that, I'll turn it over to Brian, and I'm sure we'll get into more of the details of some of these letters as we go on. But that's the context from my perspective.
That's very helpful, and I think this concept of, I mentioned how important words are. And it's interesting that, we talk about equity and we think, we talk about quality, but that this notion that driving value, and obviously that makes sense with value-based purchasing, is the way leaders are hearing this, and really getting them to understand that these issues are part of that value proposition are critically important. So I appreciate that. And this concept of performance as well is very interesting. Brian, I want to turn to you. So you live in D.C., work in D.C., kind of live, eat, and breathe both the policy and the politics. You've done some work on healthcare reform, including a wonderful report that looked at how equity fits into healthcare reform. Give us some of your observations above and beyond what Tom has mentioned as it relates to healthcare reform and kind of some key ABCs for folks. Yeah.
Sure. Well, first, thanks for having me, Joe. This is a wonderful conference, and I thought your talk teed this up beautifully. The summary of the issues and where we are, where we need to go moving forward is so critically important. Tom referenced the Supreme Court decision in late June, and that was obviously critically important. So I guess the one take-home I'd like to leave folks with is that obviously the Affordable Care Act has important implications for driving equity and quality, making those synonymous, which I think is one of the key themes that we're addressing here. But it's not a panacea, and it's certainly not enough. I consider it actually a first step, which may be a surprise to many, given how difficult it was politically to move this. Much more needs to be done to address the many issues, the complex factors that drive the inequities that we see. Many folk here are dealing with the inequities that we see at a broader societal level at the back end. We see that we see it in the clinical presentation, but of course many of these issues have their roots deeply in broader inequality and racial inequality in particular. What does the Affordable Care Act do? Most folks are concerned about the coverage provisions, which are critically important. And obviously, much of this is driven by the provisions in the law that would expand Medicaid to those who are making a little above poverty, about 138% of the federal poverty level. Currently, many folk are concerned about what many governors will do and what state governments will do in terms of enacting Medicaid expansions. That remains to be seen. But the point here is that the potential to cover more people, many millions more, is significant. We need to obviously encourage efficiency in our systems, and this is one very important way to do that. So I know many of us, we will certainly be following what governors do very closely, and we'll attempt to make the case, both in terms of human lives as well as the benefits of coverage expansions for states. We'll attempt to make that case so that these governors feel enormous pressure to go ahead and enact coverage expansions through Medicaid. Many of the other important provisions of the law have significant implications. One of the implications of the Medicaid reform that I think is very significant for this conversation is the potential to encourage providers to accept more Medicaid patients by providing reimbursements that roughly will approximate those of Medicare going forward. So in a couple of years, we'll see those provisions begin to kick in. And that's obviously very important because part of the driver here in terms of the delivery system and how we pay for care is whether or not providers are able financially to accept a program like Medicaid. Medicaid will become increasingly more significant and obviously has important implications for communities of color, About half of the uninsured, obviously, are in communities of color, so this will be very important. But Joe alluded to some very, very important issues that received less attention in the context of the law and the provisions that were debated in the Supreme Court, and that has to do with infrastructure. I think infrastructure is critically important to ensure that we have a better distribution of our healthcare resources, matching community need. And this has been part of our challenge, is that fundamentally healthcare is driven by the market. And so those communities that have fewer resources are often sicker, but have lower levels of geographic and financial access to providers, primary care, specialty services, clinics, hospitals, et cetera. So we've got to ensure that through the Medicaid expansions, through coverage, through reimbursement that approximates that of Medicare, plus other provisions that encourage a better distribution of our health care workforce, as well as greater diversity in the health professions. The Title VII and Title VIII health professions provisions within the law, I think, will be enormously significant for ensuring that we have a better distribution of our healthcare resources to match community needs. Just as significant, the expansion of community health centers, also authorized under the law, will be very, very important to ensure that communities have geographic access to those providers. These are all part of the infrastructure issues that I think were not as apparent 10 years ago when unequal treatment came out. We now have a much larger and much more robust body of literature about the phenomenon of medical apartheid, as Neil Kalman calls it. The fact that healthcare remains, in many cases, separate and unequal for many people of color. So despite the fact that we no longer have Jim Crow laws on the books, there still remains a high level of residential segregation. That, coupled with differences in terms of payment and coverage, these all add into the mix of creating separate and unequal healthcare systems that we need to address, primarily through a focus on infrastructure and ensuring that our healthcare resources are where we need them. Now, there are many other provisions of the law that I think are very significant. Again, another provision that is far less sexy, received less attention in the news media, are the data collection requirements. For the first time, ensuring that we have standardized federal race, ethnicity, and primary language data collection is going to be enormously important to allow us to measure both access and quality, as well as patient outcomes. And of course, the more we measure these processes and outcomes, the better we'll be able to detect when and where we see disparities in care. And this, of course, will, in my view, drive quality in a very significant way. Finally, one other provision of the law that I think is very, very important, and again ties in with the issues that you mentioned this morning, Joe, and that is that we have to attend to social determinants of health. It's very, very clear that clinicians have only a certain degree of control over the conditions that patients are coming and presenting with. And again, as I said earlier, in many cases, clinicians are dealing with the backside of broader inequality in our society. Addressing social, economic, and environmental conditions that shape health is going to be critically important. And I think here again, the ACA offers some provisions that help us. So requiring nonprofit health systems, for example, to conduct community needs assessments, to better understand what the needs of the communities are that they serve, and to connect with other sectors that can help to encourage greater attention to improving community conditions for health. So connecting with our urban planners, our land use policymakers, with community development authorities, others that have the potential to increase investments in communities in ways that will enhance access to the very factors that help us to be healthy in the first place. Access to healthy food, healthy housing, good transportation. Health care systems do have a role to play in encouraging a greater focus and investment in communities in particular to ensure that we're better able to address those very factors that lead populations to be sick in the first place.
That's great. And I want to get back to you because I think there's some equity-specific provisions as well that are really critically important. But Tom, I want you to reflect on that because you mentioned the idealism, and then idealism runs up into reality, right? And you're in the thick of this. And so the question is, as you're out and about and traveling in Geisinger and other places like that, how much of this conversation is happening today, or is this a conversation that's like, we'll get to that, just around these vulnerable communities as now organizations become accountable for broader catchment areas. So can you reflect on some of the things that Brian's mentioned?
No, I think that we're getting down to work actually, which is refreshing as opposed to talking about how bad things are. At least I think in areas where there are ACOs. What I see happening is like in Massachusetts, where we sort of had tremendous pressure to make commercial insurance work because we're covering everyone. We have, the politicians are very focused on the cost. Then the provider organizations have said, well, you know what? We can't practice differently for different patients. We might as well go in with a pioneer ACO model for Medicare. And then we're all thinking, well, we might as well do this for Medicaid as well, because rather than being paid well below our costs, we might as well try to plunge in with a new model for Medicaid, so we can just be trying to do good population management for all the populations. And then you get past that 30% line, Steve Shortell's. So I do think that, I brought up that Steve Shortell thing because I do think that one of the important things to do is to help push your own organization past that 30% line, so that they will start to be trying to make the healthcare system work and trying to get into population management as this default way of doing business. And then when you do get past that 30% and you start, you can't cherry pick the populations that you're working on, and really making managed Medicaid work really is critical to the business viability of any organization that's not just working in a very rich suburb. And so then to make managed Medicaid work, you got to start measuring outcomes, and you have to start thinking about well, geez, the number that's the equivalent of Steve Shortell's 30% that everyone's using now is 10%. That healthcare providers can drive 10% of health for a population. I'm sure that is based on no data also, but I'm quoting it all the time too, and I'm sure you will as well from now on. But it's sort of, when you start thinking about how am I going to make Medicaid work, then you start thinking about how do I take these things on, and you start approaching it in a business-like way. It's hard, but it's for a good cause.
A lot of us, when we hear these conversations, worry about this whole idea of cherry-picking communities, this idea that are there going to be unanticipated consequences as a result of this change? And by that I mean that organizations are going to move away from vulnerable populations. Is that, you mentioned ACOs, maybe you could give people a thumbnail of the basics of an ACO, but is that a risk?
I don't really think it is. I mean, the ACOs are accountable care organizations, a term invented by Elliot Fisher and Glenn Hackbarth just a few years ago, and it's in the language now. It's one of their great contributions. So organizations like ours and many others that are now taking contracts in which they have risk based for the overall cost of care, whether for commercial or for Medicare, and it's very often 50-50 risk sharing, 50% with the insurance company or the government and 50%, but really meaningful risk, and you start focusing on a population in general. The reason why I'm an optimistic guy in general, and I may be wrong about this, there are going to be games played along the way, but to be an ACO and you are becoming like an insurance company. You need size, you need stability, and you can't really cherry pick, and you've got to be, hundreds of thousands of people, and it's very difficult to find hundreds and thousands of rich people to focus on. The fact of the matter is that the wealthier zip codes around Boston, the per member per month spending is actually higher in the commercial contracts than in the poor zip codes, because wealthy people find a way to get theirs, somehow. So you can't have the scale by just trying to cherry pick, and it's probably not good business anyway. And so I think that to have actual stability, you have to be big enough that you're going to have a fair amount of Medicaid patients. I actually think that the thing you brought up about the Republican governors who are saying they're not going to expand their Medicaid, the folks I talk to say that don't worry about that, because the incentive, it would be so stupid for them not to take the federal money. Their state will be subsidizing everyone else. Right. The analyses from the people I talk to say maybe only Texas, as long as Rick Perry is governor, will fight it off. But virtually everyone else is quietly getting ready to expand their Medicaid, despite what their governor's saying in the pre-election period. And Rick Perry won't be there forever. Yeah.
Could I just add on the Texas instance? Yeah. One of the things that's important to recognize about Medicaid in Texas currently is that I believe that eligibility is set around 26% of poverty. So you've got to be making about $5,000 or less to be eligible for Medicaid in Texas. That leaves out a whole lot of very, very poor individuals, which again, it makes little sense from an economic perspective to leave out those many millions of individuals when we're trying to recover from this downturn. There's a strong economic case to be made, in addition to the argument that Texas taxpayers, of course, are also helping to subsidize the law itself. So I agree with you. I think much of the rhetoric is just that, political posturing. At the end of the day, it's going to be very difficult from both a human perspective as well as an economic perspective for governors to turn down the opportunity to expand.
Yeah, well, being stupid has never governed good decision making, that's for sure. Brian, question about some of the equity provisions here, some additional things that you think, I know you all did the analysis, some things that you think are particular call-outs for this group to pay more attention to. Is there anything else that you would highlight? Sure.
Our analysis of the law finds that there are some 75 equity-specific provisions within the law. Everyone talked about the size of the law in terms of the number of pages, but the issue is that the provisions around equity are folded in a way that's very much consistent with the theme that we're trying to get impart here in this conference, that equity and quality are synonymous, or hopefully getting folks to that understanding. The many provisions, I mentioned just a few around data collection, around the issue of improving the diversity and distribution of our healthcare workforce. The quality provisions in many respects are also equity provisions, and I'm sure we'll have more of a chance to talk about those as well. But again, looking at the data collection provisions, the many efforts to ensure that our community health centers and other institutions that are serving vulnerable populations are well equipped to serve these populations, we consider to be equity provisions, even though they're obviously broadly tailored so that they address many multiple needs. One of the things that I think is important to understand about the law is that all of these pieces fit together. It's hard to pull out a provision, and this was the fear, of course, around the Supreme Court decision. You can't pull out provisions around no cherry picking of insurance enrollees, or denying claims based upon prior conditions. You can't pull those apart from the other provisions in the law relating to expansion, for example. So all of these pieces fit together in ways that hopefully help us advance the case for equity. More needs to be done, as I suggested earlier. Obviously, there's much more to be done in terms of expanding training programs, ensuring that our providers understand how race and ethnicity operate in the United States. Many of the issues that you alluded to earlier, Joe, around implicit bias are still poorly understood. We've got to advance the state of the science, and in particular, help our clinicians better understand how these forces operate in the clinical encounter itself, so that we're operating both at structural levels as well as at the level of the clinical encounter. That's great.
Tom, a couple quick things here. So the reflection here on this issue of value, and I think you mentioned before, there's some concern, and not to get too deep in the policy, but boy, managed care capitation, we've been there, done that, isn't that the same? This is different, right? I mean, in significant ways.
Well, I hope so. I mean, I think that we didn't like to use the word value at Partners Healthcare and the Brigham Mass General until just the last few years. I mean, until, what we would often say was that people saying value is just a code word for cost reduction. And I think that the earlier generations of managed care, I think that was largely correct. And even though there are still people who use the word value to just basically mean cut the per member per month spending are out there, I think that that doesn't need to be the way that we use it organizationally to guide our work. Okay. So I do think that there's an evolution among providers who understand that just reducing costs is never going to be a rallying cry for the people who are taking care of patients or for patients. Healthcare is about something more than reducing healthcare spending. But we do feel like cost does matter because if we're trying to cover everyone. So that's why we're trying to use improvement, being better next year than you are now, as our sort of sense of ego identity. Like if we're not getting better, we're failing, and getting better at what? Improving outcomes and or lowering costs. So I do think value has evolved. I mean, I work a lot with Michael Porter at Harvard Business School, and people use value in slightly different ways, but so I'm sort of, parroting his framework without embarrassment. Okay,
very good. Questions now. We're going to go to questions. I got plenty more, but show of hands, we have 2 mics here that are ready to go. So if anybody has a question, please raise your hand. And otherwise, I have another question here. Okay, please just let either. Oh, we have a question here in the middle. Yep, right here.
Thank you both so much. Dr. Lee, you spoke about communicating this to providers, but I'm interested how systemically we can communicate this to patients to really educate the Medicaid population in terms of advocating for their own health based on these measures. Because as much as providers are used to the fee-for-service model, so are patients. And that is particularly seen in the sort of wait until the condition is acute and then go to the emergency room state of affairs that is particularly evident in this Medicaid population. So how would you see, even in an ideal world, educating patients to move towards this model as well?
That's a great question. So,
well,
patient perspective.
We don't know. Well, we're sort of figuring stuff out. It's a really, really exciting time. And I think in a big picture sense, what my colleagues and I know that we have to figure out is how do we really function in a team where the patient is on the team, the patient is more than just a member of the team, the patient may very well be, the coach of the team, the captain of the team, but how do we, the clinicians work like a team with the patient. And so we are, we've got work going on with patient-reported outcomes, and using web portals and smartphones and iPad type, we're trying to figure out how do we interact with people all the time without having to make them come in for a visit. And we certainly can't rely upon physicians, talking to them. And I think that it's an R&D phase, but it's the kind of work that, we pay to do. I mean, everyone's got part of their job that they hate. Everyone's got part of their job that this is just like work, and then there's part of your job where you'd pay to do. This is the pay to do part. I do think that we'll make progress. We'll figure it out. But the goal is, frankly, that it can't be based upon visits. It's got to be creation of a functional team, and the patient's got to be the constantly giving information, getting information. We've been telling our teams, imagine the iPad app for your area. What would it look like? Now, not everyone's got an iPad, but they will, with time, or some other brand. But just thinking about the structure that would go into an app, that's one of the kind of things that we're doing.
Brian, you work a lot with communities. You guys had a big conference talking about place matters and that type of work. What's your reflection on this issue?
Sure, absolutely. And that was a great question. I tend to focus on structures and systems, and I think that part of the issue here is recognizing that people that inappropriately use emergency rooms, in many cases you're talking about people for whom, for generations, that was the only option. So you're trying to change behavior, raise knowledge and awareness, but you're dealing in a context where people didn't have choices in many cases. So looking at it structurally, how can we transform the way that we operate our institutions and deliver care so that we help to change patient behavior? Clinics, community health centers have led innovation in this area, being open at hours that are more convenient to patients that may have to work during the day. What about being open in the evenings and at night? What about other kinds of outreach in the community? Creating partnerships so that people understand that this institution, this health center or clinic, whatever you call it, is part of the community and is driven by community needs. So these are some of the things that we need to do at the institutional and structural level in addition to the patient education. But I think we need to be very sensitive to the historic context as well as the fact that many folk, particularly those who haven't had insurance, who may become newly insured as a result of the ACA, we're not going to change their behavior overnight. Because these are habits, practices, expectations that have built up over generations.
And we saw that here in Massachusetts, right, Tom? I mean, we didn't see a decrease in ED utilization as we increased coverage. I mean, we saw ED utilization and costs not heading right down as we might have expected as we increased access. Right?
Well, you know, and it's not just among poor people that ED utilization is going up. And I mean, there's some fascinating stuff going on sociologically with patients in general, where we have to figure out a new model for delivering care. It used to be that, like a doctor visit was like, your wedding. You knew it was 3 days until my visit with Dr. Lee, that kind of thing. But now, the no-show rate's gone up tremendously. Like, people sort of wake up and then, maybe I'll go in, maybe I won't. Because, they're not going to the movie theaters for movies. They're not going to stores for their shopping. They don't really feel like, going into the doctor's office and paying a copayment and so on for their care. And so there's a lot more, there's something going on sociologically that we have to figure out how do we adjust to, for all populations.
And just a plug that we'll be talking about, you mentioned the iPads, we'll be talking about HIT and disparities and the digital divide and those issues with Dave Blumenthal and others tomorrow. And then we'll also be doing a session on developing ED dashboards to figure out what are these sociological issues, how do you begin to monitor them and measure them. Questions from the audience. Question right here up front. Just introduce yourself, name and organization, and Kirk, it's all yours.
Kirk Dabney from Nemours. Thank you very much for stimulating conversation. Speaking of value, I think most of us in healthcare organizations have much better experience, at least with trying to at least come up with measurements for outcomes. And my question, and I'm glad you brought up Porter's work, is Porter really believes that we know very little about the true cost of delivering care. That means, in other words, do the delivery systems really understand the cost of delivering care as opposed to just what the insurance company charges are? So what sort of progress are either of your organizations making toward measuring that true cost? And then sort of further going from that to understanding how that cost relates to the outcomes, because I think unless we can get a handle on that, it's going to be very difficult to understand, whether or not there's a true cost to improve the outcomes in particularly vulnerable populations.
Well, I would say we're primitive, and I'm optimistic that over 5 to 10 years it will change dramatically, because it's going to have to, because our systems were for the reimbursement system that's existed in the past, but clearly we're going to be paid in other ways, like value-based purchasing. As many problems as there are with like dinging hospitals for readmissions, and I think probably in this audience everyone knows that that form of value-based purchasing has the potential to whack hospitals taking care of poor populations. As much unintended perverse consequences might occur, there will be something good which is happening, which is it's making organizations think about longitudinally and begin to actually track costs over episodes of care rather than a hospitalization or a visit. Clearly, there's going to be a move away from CPT level fee-for-service and DRG level fee-for-service. And so organizations are going to have to either try to fight it off as long as possible, which will be a losing fight, or develop the systems, accounting systems, so they can actually say, well, how much is it actually costing us to take care of people across this episode? And it's going to mean you've got to like actually pull data from different silos. It's going to mean you're going to have to pull providers into being completely integrated with you, trying to get doctors to become employed rather than affiliates. There'll be many things that flow from it. But it's because of the unsustainability of CPT level fee-for-service, it's going to be miserable, but we're going to be forced to learn how to do costs, real costs over time, and we'll do it.
Brian, any thoughts there?
No, I couldn't add anything to that.
Question over here. Ed?
Hi, Ed Martinez, National Association of Public Hospitals and Health Systems, and also with the Institute for Diversity and Health Management. Just a comment, Joe, on your presentation this morning. You talked about the safety net hospitals and the challenges we have in terms of infrastructure and how that impacts quality of care. I totally agree with that. Infrastructure, everything from buildings to data systems. One other point, though, I think is important to make, and this has to do with the quality measures, which themselves have not created an even playing ground where you've included safety net hospitals and health systems. And although our years of pleading and begging for adjustment, that's never been done. And because of the higher acuity of our patients and the socioeconomic statuses that they come from, that has a direct impact on how that care is measured, and that's not taken into consideration into the present payment schemes.
Yeah, and that's a great point. I mean, that idea of payer mix, I mean, we've had some real tough lessons with hospitals here in Massachusetts, right, Tom? I mean, as they move away from the dish payments and into our new model, and we've seen a lot of pain in Boston Medical Center and Cambridge Health Alliance and the like, right? I mean, that's a reality.
Yeah. Do you want to?
No, I think Ed's point is exactly right. And again, this is why I think it's going to be increasingly important that we focus on the very conditions that lead people to be sick in the first place. We don't need to tolerate the kinds of inequities in health that we see in our work, measuring health status across different geographic spaces. We find in many communities a 20, 25, sometimes a 30-year difference in life expectancy based on your zip code, which strongly suggests that we need to look at conditions in neighborhoods, address the distribution of health risks and resources. It doesn't directly deal with the pain that you're talking about, Ed, but we've got to deal with these kinds of issues so that our safety net institutions are not being held to account unfairly because they're dealing, again, with the back end of that broader inequality.
Right. And then my question is, within the whole spectrum of health reform and payment reform, where do you see the future of the safety net?
Well, it's not going to work. We're not going to be. You got to cover everyone. I mean, the insurance reform part at the top, which I think is, the most important, is you got to commit to covering everyone, and you're going to have to make safety net institutions viable. I just want to say one thing about risk adjustment, because I agree with everything that Joe and Brian said, but we should be realistic about what risk adjustment can do. And one of the things that in my own organization I say is that I've got a limited budget for analyses, and I hate to spend it on risk adjustment because I've never made anyone happy with risk adjustment. I may make them a little less unhappy, or they stop complaining and they still don't believe that there's been full risk adjustment for what's really different about their population because we don't have everything that matters. So because I don't want to spend money that I could spend on healthcare, on statistical analyses, I'd rather make the framework about improvement for your organization compared to where you are than trying to answer the question, which is an academic question, which is, are you as good or are you as efficient as someone else? I mean, to a certain extent, who cares? The real answer question is, are you getting better? Are you learning?
And Yeah, and I think the key point, we're going to go to our next question here, and the key point there is, as you mentioned before, the potential for hospitals like the safety net hospitals to get dinged for disincentives. If that measurement is used, then becomes a problematic for them. Question, yeah.
Yeah, Chris Lathan, Dana-Farber. I have a question about this natural tension between cost and the segregation you talk about, especially on the edge when you're talking about models for dealing with chronic disease. You think about cancer. If you look at where technology is going, if you look at how people are trying to access technology, what I'm concerned about is that as you tier out these new insurance plans, patients are actually going to have more difficulty getting to some of these treatments, which cost a lot. And on some of those treatments that aren't very useful, that's fine. But there are some treatments that are very useful. And I just haven't seen yet, I'm worried about really worsening the disparities gap that we see every time a new technology comes along, every time there's a new targeted therapy. These are going to not go to these vulnerable communities. I just wanted to know if you guys can comment on that.
Yeah, I couldn't have said that any better. And this is part of the concern, that as new tools emerge, those new shiny tools always go to those that can best afford them. And so these inequities could very much deepen, as you pointed out. We still have tiered insurance. Those folk who have Pinto-level plans will not get the new tools to the degree that folk who have Cadillac-level plans have. So really, ultimately, we're going to have to come to an understanding that tiered insurance, again, encourages inefficiency that hurts all of us. And so I'm among those who hopes that at some point we're going to have a single comprehensive high-quality plan that everybody can be enrolled in.
Well, I would also say, though, that the money's still going to have to come from somewhere. And I don't think we can suck the money out of the schools and the libraries and the other things that society needs. And I think that the front page of the newspapers today about the genetic insights into the breast cancer. I think the era where we're going to be typing major cancers and tailoring therapy, I think it's going to be fantastic. Many of us here are going to benefit from it. And we're going to want it, and we're going to get it. And I would like to believe by tailoring therapy, maybe things will be less expensive, but I'm not counting on it. I think it's going to be a huge financial challenge for us. But I think fantastic. I would never want to go back in time. I just think that means that's why we have to do everything we can to be efficient with the other stuff. I don't like it when friends and colleagues might say better quality costs less. That's our way out of it, and because we know that's simplistic. We know this other stuff is coming, but we better be efficient on the stuff we can so we can afford that other stuff.
Okay, two quick things now. We promised everybody the one area that we haven't covered, and I got about I feel like I'm on the radio. I have about 30 seconds here. Just to the patient-centered medical home. So we've talked about value and value-based purchasing. We talked about accountable care organizations. Patient-centered medical home. How does that fit into this puzzle now?
Well, it's a big part. It's not the whole puzzle. And patient-centered medical homes, I think most people here probably know, is when you re-engineer primary care practices to take care of populations, take care of high-risk patients, put high-risk case managers in there, really reduce readmissions, do a better job with chronic disease. In truth, I think you need a medical village, with the specialists and the local hospitals. If you read the Boston Globe front page today, you'll see, the CEO of Partners saying, this is what we're trying to do at Partners. We're not just trying to be the 800-pound gorilla taking over the world. We're trying to create medical villages. And so we have given a lot of thought to that. I think but remodeling primary care, I think is hugely important. I can tell you, Geisinger has a new insurance product now with more than a year data where instead of tiering hospitals, they tier physician practices so that patients have a lower copay if they go to a primary care physician that meets the criteria of a patient-centered medical home. And they've found 40% reductions in admissions and ED use and better blood pressure control and so on and so on. I mean, it's the right direction. It's extremely disruptive for physicians to change what they do, but it's a good thing to do. It won't be enough, though. I honestly do think the medical village, part of the overall community focusing on caring for the population efficiently is the next step.
So to end, what we want to understand is how we can help these, these movements, and they're really one movement the same. But as we think about healthcare reform, as we think about payment reform, Brian, I'll start with you. From your view in D.C., there's still a sense that a lot of these issues are subject to appropriations. What are the ways in which we could be engaged to integrate? I'm going to change it now and say value, right? Which under that rubric is equity and quality, into where our healthcare system is going. Is there one or two things or three things you'd leave this group with that they can be active on?
Sure, absolutely. Well, obviously the first one is a no-brainer. Be engaged. We've got to help policymakers understand how these issues play out. All of you who have the experience, I'm assuming most of the folk here are folk who've been following the Massachusetts model, understanding how reform has played out here. So important that you share your perspective and knowledge with elected officials in Washington, because they're often talk about making decisions not based on data. Decisions are made based on faith, not facts, unfortunately. So we've got to help share the understanding of how this works, and then helping people to very much understand the vision. I love the medical village model, and I think it's an appropriate one. Now our challenge is putting that village where it's needed. And I think that's one of the key challenges when it comes to eliminating disparities and advancing a broader health equity agenda.
What's interesting here, just to add one little thing there, is that that it seems like a lot of the stuff that we've been talking about, the public hospitals have been talking about, the community centers have been talking about, all these issues that are important in the care of patients, that the cost mechanism is now catching up, Tom, right? That this idealism that we've been talking about, that there's now an opportunity to say, oh yeah, community health workers, navigators, coaches, these types of things, yeah, they need to be built in and they're going to be paid for. So to you, Tom, you mentioned several times that you're in R&D, that this is primitive, that, that there's a lot of learning going on. How can people help feed you information that could help you so that this doesn't get drowned out or so it doesn't just get lost in the shuffle?
Well, I think that the creativity that we need on that delivery system reform level, none of us know what to do. But we know that we have to figure it out, and so it's a very exciting time. I mean, I would be saying, if you think about the three levels: insurance reform, never waver. Do everything we can not to let the country slip away from its commitment to broaden coverage. Payment reforms, like push for new payment models, push your own organization to be ready to go down that road, scary as it is. But then really, we all should be ready to sink into the work of redesigning care. The delivery system reform is really fun, but it is work. It's really hard, and it takes a lot of, you're going to fail, but you got to be ready to bounce back. You got to be willing to learn from other folks who are doing things. And again, I feel like you'll get more done if you say the work is about improving value for patients, as opposed to any more specific agenda.
Are you hopeful?
I am. I think that we are turning a corner. There's much more that needs to be done. But I think we're beginning to understand that the combination of demographic change plus the economic pressures around healthcare costs and the need to ensure that we have a healthy population so that we can get out of this economic downturn, all of these kinds of pressures are helping people to get it, that these are not just issues that folk like us need to be concerned about, but they're broader issues that every policymaker, every healthcare professional has to consider and be conscious of in our daily work.
Tom, you said you're optimistic, you're hopeful. I mean, is this the right conversation to be having?
Oh, it absolutely is. It's a thrilling time. I wouldn't want to be working in any other era. But now, we do have to kind of like put up or shut up.
Yeah. Please join me in giving them an applause. Round of applause. So we started to cover some of the ABCs. I think this point has been reiterated time and time again. This is real. This idea of it's all happening fast, nobody has the answers, I think should embolden us to get in there. And I think the other couple points that I love was this kind of point of the 30%, the 10%, that these things catch on, and so we need to think about our own mantras that are communication strategies to catch on to continue to drive and integrate this work. We're going to take a 10-minute break and return here at 10 o'clock with our next set of respondent panels that will talk about the hospital health plan and health center constituencies and how they're responding to these pressures. Thank you. Enjoy your break. Thanks so much, Tom.